When you hear that trumpet, you know it's the Dr. Larry Show on the Bachelor News Radio Network, and I'm Dr. Larry Fedewa. I'm your host for the next hour. Before we get started tonight, I wanted to mention that a podcast of our very important interview with Dr. Edward Creagan of the Mayo Clinic is now available on YouTube. If you go to www.youtube.com, and when they ask for in the blank the search term, put in Dr. Larry and Dr. Creagan. Creagan is like Reagan with a capital C, and you'll see the text and hear that very important to us anyway interview with Dr. Creagan tonight, and below that, by the way, is another version of this. It's the Donaldson Files, immediately followed by the Dr. Larry Show, and that's the same night. If you're in a hurry, you can listen to the Dr. Larry Show, and if you have more time, you can hear one of our great other programs, the Donaldson Files, which is recorded before our show, and our show would start on that version at 2:20:00, which is the second hour. Tonight, we want to talk about. Essentially, we're talking about the insurance company aspect of our proposal for reforming a free market version of American health care. Before we get into that, though, I want to give you a brief summary of where we are in terms of the proposal itself, so that we're if you refresh your memory from the last week, the key points are: number one, the goal of any new healthcare proposal must be to develop a patient-centered system. That is, a system which provides the patient the ultimate power to make his or her own medical decisions, which can be a matter of life and death. A secondary goal is to reduce to 2/3 of the medical cost that the U.S. spends every day or every year, which is between $3.5 and $4 trillion, thereby reducing the cost of health care to the consumer, who is every American family. The 5 major obstacles to these goals in today's system are: first, a critical shortage of medical personnel, and secondly, employers; third, federal government; fourth, state governments; and finally, health insurance companies. The solutions we are recommending to overcome these obstacles are, first of all, medical personnel shortage. We're recommending that the U.S. Public Health Service or some other appropriate federal agency offers a full cost scholarship in medical, dental, paramedic, nursing, and similar fields to any qualified American student who is willing to serve a 2-year term in a designated practice where critical needs exist at the conclusion of the field of study. The second is the employers themselves are relieved from all responsibilities of medical insurance, which is a big relief for most of them. Thirdly, the federal government actions. The federal government maintains Medicare because of ethical and legal obligations, even though it may undergo gradual change. Secondly, the federal government declares medical insurance to be an interstate commerce, subject only to federal regulation, with one set of rules governing all medical insurance, and thus eliminating a major cost driver for health insurance, which is that any company that wants to cover a particular state has to, in effect, create a bureaucracy of its own to deal with all the differences in health insurance state by state. And finally, the federal government sets limits on settlements for medical mishaps, ending the need for defensive medicine and the extremely generous fees for the trial lawyers who have in essence created defensive medicine. State governments were suggesting that the state responsibilities be limited to practitioner licensing for medical personnel and only the following specific responsibilities. The first of which is the management of a funding pool for indigent patients based on a small per capita tax of each buyer of health insurance, which is a critical component to universal coverage. Perhaps a restructured Medicaid without federal involvement might fulfill this need. And next would be oversight of standard business procedures governing organizations of private citizens designed to provide health care insurance, whether it be church or credit union or cooperative, small business associations, neighborhoods, or any other type of structure. This feature is key to the lowering of health care costs by increasing competition for the patient dollar in the extended field offered by reduction of individual state requirements and the end of defensive medicine. And finally, insurance companies. There's still a place for insurance companies, albeit radically altered. The first factor to be considered is the new phenomenon of literally thousands of new organizations which would emerge as the market for insurance carriers. This is a whole new opportunity for these firms to seek out new buyers, to develop new packages for buyers, representing basically a new constituency, all anxious to maximize individual benefits to a much more vocal and demanding membership, and then to formalize the flexibility ceded to each member to choose treatments and decisions themselves, rather than accepting bureaucratic stipulations blindly. Companies which cannot adjust to the new markets will not survive. Another opportunity will also arise, namely the custody and development of medical savings accounts. One of the first trends may well be simple transfer of the new payroll income from health insurance premiums that are no longer deducted from payroll for the transition to a medical savings account. The recipient of these deposits may well be in a new branch of financial management, and who better to do so than the high credibility of your familiar insurance agent. Finally, there will be some differences in how the average person deals with his or her health care, but not that many. The two most significant are: one, you will become the direct buyer of your own health care with the money you save from your enhanced paycheck. And two, you will be making the sometimes life and death decisions that are now made by budget-watching bureaucrats in insurance companies or the government. And that's it. You're listening to the Dr. Larry Show on the Bachelor Pad Radio Network. This is the Dr. Larry Show on the Bachelor News Radio Network. And I'd like to now welcome to the Dr. Larry Show Scott Stevens, who is a employee benefits and consumer directed healthcare broker and consultant, and a trusted advisor to helping employer organizations of all types reduce their health insurance and related employee benefit costs. He's worked with thousands of organizations, and he's considered a national expert in the field, and he knows a lot more about healthcare insurance than I do. So, Scott, welcome to the show.
Thank you, Dr. Larry. It's my pleasure to be on the show tonight.
Well, could you start by I'm sure that you have a lot of activities going on your resume, and are there any particular ones that you'd like our audience to know about tonight?
Well, yeah. In fact, I've dedicated probably the better part of my 32-year career in this space to an awful lot of what you just enumerated in your reform protocol. Chief among that is making the typical healthcare consumer a better, wiser, better educated, more prudent consumer of healthcare, and that is a very high task. It's a very high burden, just because of the way our healthcare system has functioned for the better part of the last 60 years since World War II, which, by the way, is when employers found themselves in the business of healthcare. A lot of people don't realize that, but
right.
Post-World War II, with wage controls, somebody had a bright idea to offer healthcare as an incentive to get people to come to work. Well, I can tell you from being in this space as long as I have that many employers, the vast majority, would welcome the statement you just made about being relieved from the burden of having to provide employee benefits, specifically health insurance. So I am a very strong advocate of what has become to be known through the media and other outlets as consumer-driven healthcare.
Right.
And that is the goal of trying to reduce, if not outright eliminate, this perverted third-party payment system that is very unique to healthcare, and you will be hard-pressed to find in any other component or facet of our entire economy. And it takes all the basic principles of free markets and capitalism out of the equation, quite frankly. So in my practice and in a lot of my writing and speaking, I try to educate people on using the tax code and things like health savings accounts and health reimbursement arrangements, flexible spending accounts, and maybe a combination of those for the more predictable non-catastrophic expenses, and then use health insurance as it was originally meant to be for the catastrophic, non-predictable, bankruptable types of expenses. And that's really what I do primarily, Dr. Larry, in my practice.
What kind? I saw your 7-step recommendation for reform. Do you want to quickly go through that for our audience?
I'd be happy to do that. And as I always, my wife doesn't let me go to cocktail parties anymore because of this topic being as controversial and lightning rod as it is. But so this is a pleasure for me to be able to have this outlet. So I thank you for that. And whenever we have a conversation such as what we're having right now for your listeners, it really needs to begin with what is the best healthcare system for the United States? Is it as it has been, is it a private, market-based fee-for-service system with some government involvement, but largely a profit-based, market-driven system? Or, by contrast, should we move in the direction that our neighbors to the north in Canada and a large number of our friends in Europe have gone to, which is some form of a single-payer, universal type of a healthcare system? And when I start the conversation there, oftentimes, and from all different political beliefs and ideologies, a lot of people lean more towards that universal government-run system because it sounds so great. Everybody has care. Nobody has to worry about insurance. Everybody can get to the doctor when they need it and get the care they want. And the reality is there are significant trade-offs to that form of system. So as I kind of go through the tenets of my 7-point healthcare reform plan, it presupposes that we're in agreement that we want to maintain less government involvement and more of the free market capitalist type of an economy that fuels everything else under the sun here in the United States. So the first thing is the Affordable Care Act, while perhaps well-intended, has had a lot of ill-intended consequences. And probably the biggest one of those, the most damaging one, has been driving out insurance companies from the markets. And I know we kind of have a love-hate relationship. You want your insurance company there when you need them, but you hate like heck to have to pay premiums that go up every year, and you hate like heck to have to fight them tooth and nail to get a claim paid. But the reality is, if we're going to have this free market, lightly government-regulated system, we've got to have insurance companies willing to sell products and administer coverages, provide service, et cetera. So, my starting point for reform is we've got to dial back on some of the more onerous provisions of the Affordable Care Act to lure back to the markets the insurance companies. And part and parcel of that, and another aspect to my reform plan, is we've got to let the insurance companies, and I think this is in alignment with you, Dr. Larry, you've got to let the insurance company design creative plans, catastrophic plans that appeal to a broad spectrum of consumers. One of the things the ACA, the Affordable Care Act, did was to create a very standardized set of plans that the insurance companies that decided to sell could only sell, and we call those the metallic series because they are bronze, silver, gold, and platinum. Yeah. And if you are an insurance company selling in the small group or individual market, you can sell, and you can only sell those 4 plans.
Well, the other thing is the market itself. If we took employers out of the market, then we've got a whole new constituency that really calls for a lot of originality and creativity and innovation and personalization, because that's what they're going to be looking for. It's not.
I couldn't agree more.
It's not the standard employer who just wants to get this out of the way as fast and as cheaply as possible.
Well, and to that point, so here I always say to my prospective employer clients, and even on an ongoing basis at the risk of my own financial peril to my existing clients, is here's the decision tree. Do we need to offer health insurance to our employees or not? And if the answer to that question, if you can hire and retain the talent that you need to run your business or your organization in the absence of offering health insurance, then don't do it. On the other side, of that decision tree, if the answer to that question is, in which I oftentimes hear, oh gosh, Scott, no, there's no way I would have a sucking sound of people leaving my business, my employee, if I, decided to eliminate my health insurance. And in that case, the decision tree says, okay, then let's decide on and let's formulate and let's deploy what makes the most sense in terms of a health payment system, not just health insurance, but a combination perhaps of spending accounts and a myriad of newer innovations that have cropped up on the scene in the last 15 years since the dawn of this so-called consumer-driven healthcare movement. I mean, I could talk all night long about things like virtual care or telehealth. MD Save is a new company that just launched within the last 18 months that offers vouchers, prepaid vouchers for healthcare, spending accounts. GoodRx.com, which is a wonderful resource for low-cost prescription drugs. Excuse me. In short, just ways of paying for the lower-cost expenses without relying on insurance.
Well, if we could get the employers out from under the burden of offering health insurance, and we almost have to do that if we're going to try to get the consumer to be in charge of his own fate when it really comes down to treatment. We were talking to Dr. Cragen about the fact that so often it comes when really critical situations occur. The people actually causing the treatment to go the way it goes are the insurance people, and neither the physician nor the patient, and that's just wrong. That is not that's not where we want to be.
Well, I have a lot to say about that. First of all, Dr. Ed Cregan is an old friend of mine and a colleague, and I very highly respect his input on this issue.
We'll just step aside for a second. This is the Dr. Larry Show on the Batchelor News Radio Network. You're listening to the Dr. Larry Show on the Batchelor News Radio Network. We're talking to Scott Stevens, who is a national expert in the field of healthcare insurance, and we were about to start talking about some of the other aspects of consumer-driven healthcare. You were on about your third or fourth point of 7 points, right?
Well, yeah, we're getting there slowly but surely. So getting back to the point that Dr. Ed made last week, and really a major challenge.
Who's in charge of treatment?
Right. So let me give a little perspective, maybe a little historical background on how that even came to be, because it wasn't always that way, Dr. Larry. So as health insurance costs began to spiral out of control in the probably late 70s, early 80s, and healthcare payers strive to find the so-called silver bullet on how to contain those costs, the whole notion of what I call supply-side healthcare reforms and managed care was born. And managed care was kind of an umbrella term, but what it meant in short was that the payers of healthcare, which are in large measure the insurance companies, would intervene and become very much hands-on involved with determining what type of care would be provided and by whom, how much of it, and in a lot of cases even an up or down, kind of the old Roman emperor, thumbs up, thumbs down on whether care would even be allowed. And that was, again, an attempt to constrain escalating healthcare costs by the use of supply-side healthcare managed care mandates. And some of the examples of that are HMOs, PPOs, preferred provider organizations, point-of-service, POS, point-of-service plans that featured gatekeepers, where you had to get permission from a primary care doctor to seek care from a specialist, mandatory second surgical opinions, and then the real big one is pre-certification or utilization review. I'm using a lot of terminology here, but these are the tenets of the so-called managed care. And what utilization review or pre-certification meant was before one could get the care that their provider was largely recommended, they had to get the permission and the approval from their payer, which in most cases for 160 million at least people in the employer market was their insurance company. And that's very unfortunate and not to the point that you've made in your missive or your document about healthcare reform, Dr. Larry. I couldn't agree with you more. We've got to get away from that, where the consumer, or in this case the patient, has a direct relationship and direct dialogue with their provider, and they alone determine the correct course of action, the correct protocol for healthcare.
But that's going to take some creativity in the writing of the insurance contracts.
Oh, it is. Well, actually, it's got to start where we sit right now in 2019, soon to be 2020, with some tweaks to the Affordable Care Act, because as it stands right now, there's very little flexibility for healthcare payers to develop plans that are compliant with the Affordable Care Act, because they've got to stay within that rubric of the metallic plans. So we need to start with reforming the reform, so to speak, and I've written quite a lot about that. And again, it's part of my 7-point healthcare reform plan. Is certainly not repealing the Affordable Care Act. In fact, that's one of those reasons why my wife doesn't let me go to cocktail parties. Is I don't think it's a good idea to repeal the Affordable Care Act. There are some very good things embedded within the Affordable Care Act, but there are a lot of things, or a host of things, that need to be tweaked, modified, repealed, partially repealed. And that's some of what I get into within the context of my reform plan. I think you talk a little bit about Medicaid within the confines of your reform initiative. There are major improvements that could be made there through the use of block grant funding. That's a number 4 of my 7-point reform plan. so that you give the states much more autonomy and flexibility to deal with their own constituents and their own residents within their states. Let them figure out, maybe creative, unique ways, perhaps using consumer-driven health plans or telehealth or virtual care, a lot of these things that I've talked about before, to lower cost and to get a better, more engaged consumer.
Well, let me make an issue of Medicaid as a. I think it is. I guess I would assume that it is a welfare type of activity, and really, the funding of it. That's a lot of where the federal funding comes in. And if we did away with the federal funding, we have to substitute something else for that. And I don't know the economics of this precisely enough to be able to speak to it in detail, but I'm sure you do. How would that work?
Well,
is that even possible?
Well, I think everything's on the table, Dr. Larry. I think, This is one of those, desperate times call for desperate measures. And as I show some of the graphs and charts when I do speaking engagements on the trajectory of health insurance premium costs, clearly we've got to do something. This is not a sustainable model that we're in. Right. The Affordable Care Act, again, while perhaps well-intended, has not really helped things. It's in a lot of cases made things worse in terms of premiums and out-of-pocket deductibles. So we've absolutely got to get to the root cause of a lot of this stuff. And I guess that's where I'd like to pivot to at this point, is that, as you've mentioned and written, we spend as a country almost 20% of our gross domestic product on healthcare. Right. And that is in the area of $3.5 trillion. That was the bill in 2018, and that is more money than the entire gross domestic product of all but about 4 or 5 countries in the world. Right. So what we spend just on healthcare outstrips what the majority of the world spends in their entire economies. But what really gets people's attention when we start to sort of drill into that is the fact that many, many experts, and you can find this in a variety of sources, many experts predict that as much as 75 to even 85% of that toll is attributable to chronic or preventive conditions. So if we, once again, getting back to making a smarter, better, more prudent healthcare consumer, we've got to be better about our lifestyle choices. We've got to get our arms around this obesity problem in America, which is frightening. Now we were starting to make strides on nicotine consumption through smoking. Well, now we got vapes, which in some cases might even be worse in terms of a lack of control of the amount of the drug that's getting in your system. Wearing your seatbelt, wearing a helmet if you're riding a motorcycle, being smart about alcohol consumption, all of those kinds of things. If we could be better at those things as a nation, we could make dramatic improvements and reductions in the amount of healthcare expenditures.
Well, that certainly is understandable, but I also am still interested in, if we were to get the government out of the Medicaid business, where does the money come from?
Well, that's the problem. Is right now that it's about a 90-10 funding arrangement between the federal government and the states, where the federal government picks up, roughly.
We'd like to get the states out of it too.
Yeah, well, we have to find a way, and again, I believe it should fall on the states, in the various health and human services departments of those states, with a block grant funding mechanism to get the necessary funding, and then pools for the unhealthy. And that's, I guess, another tenet of my reform plan is you can't force the sick and the unhealthy into the same insurance pool as the healthy and the lucky, I guess, or the blessed, people that don't have chronic health conditions. You've got to separate or bifurcate those two pools and then accommodate the sick and the needy and those that consume large volumes of care with a subsidized system, a subsidized health insurance and healthcare financing system, and that frees up untold dollars and, for that matter, creativity in the marketplace to design insurance products and funding mechanisms for the healthier, less needy.
Well, I certainly would not argue with that, but I also think that another way to dramatically increase the efficiency and the productivity, which is another way of saying reducing the per capita cost of healthcare, is supply. And again, I'm quoting Ed Cragen. The statistics that he cites are that within a very few years there will be 100,000 physicians short of basic coverage for the United States population. And my point on that is that we have a national crisis because we don't have enough physicians to cover all the areas now. And as he will tell you, and many others, I think it's the second highest. This is shocking to me. The second highest cause of death among physicians is suicide. So I mean, we're not even treating the ones we have very well. So that issue has to be injected into this whole equation in a very dramatic way, I think. And I'm just thinking of the way that we as we deal with the military officers, we have federal scholarships that cover their expenses if they're willing to give 2 years of their lives. I think it's still 2 years in the service. I see a very similar thing should happen with the medical profession, all the medical professions. That there are many of them. If we had a surplus of physicians, I think the whole cost of treatment would go way down. The other part of that, of course, is technology, but nevertheless, it seems to me a fundamental and very critical issue. You're listening to the Dr. Larry Show on the Batchelor News Radio Network. You're listening to the Dr. Larry Show on the Batchelor News Radio Network. We're talking tonight about healthcare insurance and all the cost drivers that Scott Stevens has been enlightening us about. And we left on this issue of supply of physicians and medical personnel in general. I didn't see anything like that in the parts of your discussions that I actually got to. I must admit I didn't get to read everything that you've written, but how do you feel about that?
Well, that's one of those areas, or one of the reasons why I stay in touch with people like Dr. Ed, because that's certainly out of the purview of somebody like me that makes his living more on the healthcare financing side of the equation. But the lack of interest in providing healthcare as a career is a very real and serious challenge facing the country that Dr. Ed did a very good job of talking about last week, and you brought it up again tonight. And I am aware, just in doing the research and the reading that I do, that is a very real thing. And perhaps even more challenging is the fact that the kids that are coming out of medical school today, less than 2% of them, that I read, less than 2% of them choose preventive care as their area of focus because the big bucks are in specialty care.
Or even general practice.
Or general practice, yeah, or any internal medicine, or any of the primary fields, which is where we so desperately need to have care. And obviously, that one of the things that we're seeing in my state of Nebraska and many other states around the country is much more reliance on and use of nurse practitioners and physician's assistants
Yeah.
to provide that critical
even they're
primary care.
limited. They're also very
They
limited.
are. They are,
mean,
and states regulate what they can do and how they can prescribe and all those kinds of things. But yeah.
Well, plus there aren't that many of them anyway.
Well, they're a growing number, and as parents seek my advice on what their kids should major in college, and I've got soon to be a freshman, one more year in college myself. When people say, what are the hot careers, or where should my kid go to school so they can pay off their debt and start making a living? And my first response always is physician's assistant or nurse practitioner, because the barrier to entry, it's 4 years undergraduate, 2 years postgraduate, and you are in a job that could be making you $80,000 to $100,000 a year.
Well, I guess one of my major careers, unfortunately, I guess I couldn't hold a job. I had so many different fields that I got into, but one of the areas that I got into with Johns Hopkins was public health, and the issue that that kept coming up when we talked to all these bright young guys, and they weren't all young either, and they weren't all guys, but the bright people, I guess I better say, was that there's no lack of interest or desire to be a physician, or to be dedicated to the very altruistic and noble goals of medicine. The real problem is they don't have money, and so many of the physicians that we now have in practice are actually coming from foreign countries, and so you wonder, why, what's going on here? And as a former college president, I can tell you that one of the big blockages is the nature and extent of and the cost of the medical education, whether physician or any other medical field.
No question about it.
So that is also an area that really, really needs attention, and the impact on cost. I think of that $3.5 to $4 trillion we're talking about. A lot of it has a portion of it anyway would be taken care of if we did a better job of getting our personnel situation straightened out. Okay, well, I don't want to preach, but
well, let me just, I want to comment on something there that you just brought up. It's absolutely true that the barriers for young kids seeking a career in healthcare are tremendous. I have a very good family friend whose daughter-in-law obtained a medical degree, and was wooed to rural Nebraska for a position. Very nice salary, excuse me, and some abatement of her student loan debt, which was significant. And in speaking to her recently, even though her new employer took care of well over half her debt, she was still facing loans in excess of $150,000.
yeah.
Which I couldn't even believe, because part of the lure for her to go to rural Nebraska to practice in her initial career was the forgiveness of a substantial percentage of her medical school loan debt. And even with that, she still is making monthly payments for her student loans. So the other thing I wanted to just mention there real quick, when you talk about foreign doctors, Dr. Larry, is the advent and the growing popularity of so-called international medical tourism.
Right.
And make no mistake about it, that is a very real strategy and opportunity that employers are taking advantage of in order to significantly reduce their outlays of cost, and in many cases get care from American-trained doctors, but in locations that have different, certainly malpractice rules and different fee schedules, lower fee schedules.
Well, the entire world, everybody criticizes the American system, but the fact is, when they get really sick, where do they go? They come here.
No doubt. Yeah,
and,
that's a fact.
And that's partially because of our technology, which in most cases, in most fields, technology tends to be the lessening of human labor. Really, it's a labor saver. But in medicine, it seems to have gone the other direction. It seems to be absorbing all of the the top talent that we have, and costing more than it did before. Than it did when human beings were doing all of these things. So there's something there too. I don't know enough about that to be able to comment intelligently about it, but I do know.
Well,
my years at Control Data showed me a lot about how technology works, and technology is supposed to make things cheaper. The unit of output is supposed to be cheaper because of automation, not more expensive.
Well, if we have time, I don't know how much time we have left, but I'd like to talk about the Affordable Care Act's so-called healthcare delivery reforms, which people rarely want to talk about or understand, but it strikes right at the heart of what you're talking about. We got another 15 minutes,
so have at it.
So, and if I can pick on MRIs, magnetic resonance imaging, as an example, when that technology first came on the scene, probably 20 years ago, the cost of MRI images were in the vicinity of $4,000 or $5,000. I can direct people now online to different cost treatment estimators where you can find that procedure for as low as $350, Dr. Larry.
Yeah, but no, wait a minute. This is something I do know something about. The cost, generally, the cost of high technology is that it is factored into the final cost to the buyer, is all of the research and all of the preparation that went into creating the first workable model of it, and then after that, it's cheap. I mean, it's like you create a course for a college course. In history, and it's writing the book and getting all of the taping done and all that. That's very expensive. But then when you finally get the final product, each copy costs pennies. And so somebody is, I mean, if we wanted to cut the cost of medical technology, we could do that with taxes, with the tax policy.
Well, I think the
R&D, if R&D were a deductible expense, you wouldn't have these high costs.
Sure. No, I agree. And as we talked before about trade-offs between a for-profit, market-driven healthcare system versus government-regulated, that's the reason why we have so much innovation and so much R&D and so many different types of innovations like MRIs as an example, whereas some of these other countries that deploy a single-payer government system, they don't have that. They're not having that. They don't have the incentive, and so they're not having those types of innovations.
But we're doing it at a tremendous monetary cost, and
we are indeed.
I'm suggesting that is one cost driver that could be remedied rather easily.
Well, and again, it's all part of this elaborate network of reforms, and I know that you've talked about this too, medical malpractice. We've got to get malpractice reform is central to this because we have this high cost of care, and oftentimes providers are ordering tests and running tests and ordering different procedures merely to defend the possibility for malpractice litigation. Exactly. And that's, you can't really blame them, but it's an unfortunate layer of cost that's added on to an already labyrinth of expenditures and costs. So central to part of my healthcare reform initiative, and I know part of yours as well, is we've got to get some type of medical malpractice reform at the federal level, because frankly, that's one of the reasons why you have differences in costs throughout the state. Some states, like my state of Nebraska, have caps on punitive damages. So naturally, medical malpractice insurance is going to be less costly here, and doctors here will be less inclined to perform defensive medicine knowing that they've got the protection of a state cap on punitive damages. That is not the case in a large number of the states.
Oh, no, not in most. We're going to take a break. This is the Dr. Larry Show on the Bachelor Radio, Bachelor News Radio.
It's the two megastars summer mashup, the awesome iPhone on the Rockstar Metro PCS network. Get the iPhone you've always wanted for $0, so you can jam without limit.
It's a hit. Get an iPhone SE on us when you switch. Metro PCS. Coverage not available in some areas, plus sales tax and $10 activation fee. Requires port in of number not currently active on T-Mobile network or on Metro PCS in past 90 days to an unlimited LTE plan. See store for details and terms and conditions.
Blog Talk Radio.
You're listening to the Dr. Larry Show on the Bachelor News Radio Network, and we're talking about some of the major cost drivers behind this tremendous cost of our really inefficient medical system, which actually doesn't even provide a universal care, even though we're spending so much money. And some of the cost drivers that we've talked about tonight have been the personnel shortages, the technology, the cost of technology, but these are on the treatment side. And then the other factor is that where we actually end up having very close to universal care, even though we don't call it that, is because the hospitals are carrying a good deal of that expense for the indigent.
Yes,
and it's getting so the hospitals are almost to the point where, well, they're disappearing because they're consolidating, and then they get the efficiencies of volume, but they're also gradually diminishing in their services. What are your thoughts about that? You must have given that some thought.
Yep, that's a perfect segue to what I started to talk about. This conversation is obviously moving in a lot of directions because we have a lot of different things to talk about and cover. But so embedded within the over 2,000 pages of the Affordable Care Act, or as some like to call it, Obamacare, were incentives to move the healthcare delivery system away from its historical fee-for-service model to a fee-for-value model. And within that came the construct known as an ACO, or an Accountable Care Organization.
What in the world is that?
So accountable care organizations are, in a lot of cases, the alignment of the healthcare financing and delivery sector, so where we're finding insurance payers, in a lot of cases insurance companies, or even the federal government or state governments, actually becoming more involved with or partnering with healthcare financing providers such as insurance companies, and the government or the plans that these ACOs serve reimbursing care to their customers or patients on a fee-for-value model. So what that means is, in order for the providers in these accountable care models to get paid, they have to meet certain metrics of quality, outcomes, customer satisfaction, a variety of metrics that are defined and delineated by, of course, the federal government. And in that model, you are now rewarding, rather than volume of care that may or may not have the desired outcome, but rather you're rewarding the quality of the care. So one of the best examples is hospital readmission rates. So if you had within an ACO model a provider that had a high readmission rate, or a high infection rate would be another metric, they would not be paid as much for their care as a competing hospital that had very, very low readmission rates and infection rates and such. That's one metric. So, in this model is taking foot. If you look around America, these ACOs are omnipresent and Centers for Medicare and Medicaid Services, which are responsible for about a third of all healthcare consumption, are contracting with these accountable care organizations left and right, again, in the attempt to try to get lower costs and better care. You know, the sort of the triumvirate of goals: lower costs, better care, better patient satisfaction.
Boy, that certainly lends itself to corruption pretty easily.
Well, you know, I can't speak to that. Only that in this model, we are trying to get a more of an alignment of incentives between patient, provider, and payer.
Well, it's like so many other things. You know, the goals are noble and good and valuable, but the devil's in the details.
No doubt about that, Dr. Larry. No doubt about that.
Well, we're coming to the end of our what seemed like a brief conversation here. We have I always give the guest the opportunity to plug whatever his latest project is, and so I'd like to give you the opportunity to talk about anything that you want to talk about for the last couple of minutes here.
I very much appreciate that, Dr. Larry, and I kind of jokingly say I have a day job and I have a mood lighting job. My day job, which I take very, very seriously, is taking care of the employee benefits and health care and employee engagement for some 26 different employers throughout the Midwest. I have a variety of consulting clients in addition to that. But by evening, I am a writer and a speaker. In fact, I'm currently working on a book that is going to sort of try to make sense of all of the terminology and all these different strategies and laws and mandates and things. And that's something that I'm, again, toiling with. But my website is probably the best plug that I can make, which is how you can get access to my various deliverables, offerings, blog, articles that I've had published. And that is SM Stevens, S as in Scott, M as in Michael, SM Stevens and Associates.com. It's all one big long word. And within there you can access all the different things that we do and offer. And I appreciate that.
Well, we want to thank you for spending your time educating us tonight.
My pleasure.
We're certainly at the point where we have an election coming up, and in that election there are two sides, and one side is saying increasingly that they want socialized medicine, and the other side isn't saying anything. And so
right.
We're trying to fill a goal on or a gap on the Republican side, at least. Although there are some Democrats that are very knowledgeable too. I don't want to assume that this is a partisan issue, but the fact is that what we have right now is we've got a strong drift to the left in the Democrat Party, and we're trying to get together enough leverage so that we can go to the other side and just say, look, here is an option. You guys have been working on what was it? Repeal and reform.
Repeal and replace.
Repeal and
replace.
For
that's not a good. That's not a good
3 years. Well, but they haven't come up with anything. They've come up with some things, but they haven't done repeal and replace. And I think that we have taken what we're hearing is too small a vision. That it's like we're stuck with this one model, and let's try to tweak it until we get it right. I'm saying let's throw out the whole model and start with a blank piece of paper. And it doesn't seem to me that we would have too much trouble coming up with something better. Well, anyway, that's my my latest enthusiasm. So thanks again for coming on. And if people want to follow us, we suggest you might want to take a look at the YouTube presentation that's just been put up. It's if you go into www.youtube.com and they ask you, there's a blank there for what is it you want, put in Dr. Larry and Dr. Cragen, and up will come a podcast of what we considered a very important interview 2 weeks ago. It's August 14th, 2019. And there's some pros there to tell you just who we are and what we're after. So we want to say good night and God bless everybody. And listen next week, and we'll try to have something maybe even as good as tonight with Mr. Stevens. Good night.
Thanks, Dr. Larry.